Welcome to the Australian Dental Council Explainer podcast, where we analyze clinical scenarios to strengthen your diagnostic framework. This content is educational, based on Odell's Clinical Problem Solving in Dentistry, 5th edition, and is not a commercial endorsement. We are managing a 35-year-old male who presents with a primary concern regarding his dental appearance. He reports a widening space between his crowned upper right, central, and lateral incisors that became noticeable 9 months ago. The patient also notes that these teeth have drifted forward, and the crowns feel increasingly loose. Notably, this progression is painless and entirely asymptomatic. The upper palatal view shows the clinical state of these 6-year-old crowns, specifically the exposed dark margins and significant palatal recession. Panning to the lower arch, we observe a secondary diastema between the lower right canine and the first premolar. Based on this asymptomatic widening diastema, pause the video and provide your differential diagnosis in the comments. Determining the cause of this migration requires looking beyond the cosmetic changes to identify the biological failure driving them. The medical history reveals mild asthma managed with an inhaled steroid and salbutamol. Steroid inhalers can alter oral flora or contribute to xerostomia, though these are secondary factors in this clinical presentation. The dental history shows a shift in patient behavior. He has moved from regular 6-month attendance to irregular checkups. The upper restorations are 6 years old, originally placed to replace fillings described as unsightly. We can now correlate these historical details with the intraoral examination. The oral mucosa is healthy, and there are no active carious lesions. Looking at the upper central incisors again, we see focal marginal inflammation and interdental plaque stagnation around the crowns. This localized inflammation is associated with 3 millimeters of palatal recession. These upper teeth exhibit grade 2 mobility. Examination of the lower right quadrant shows more extensive involvement. A diastema is present between the lower right canine and first premolar, and the adjacent lateral incisor has grade 3 mobility. Pathological migration and mobility affecting both arches simultaneously indicate generalized periodontal failure rather than localized restorative fatigue. In an OSCE setting, every investigation ordered must be specifically justified by the clinical findings. The protocol begins with vitality testing of all teeth in the upper right quadrant. We perform these tests to exclude asymptomatic endodontic failure in the crowned teeth. Deep operative work from 6 years ago increases the risk of a silent loss of pulp vitality. An undetected necrotic pulp could cause a periapical lesion, which would contribute to localized bone destruction and tooth movement. The second diagnostic branch involves radiographic imaging. We require periapical views using a paralleling technique to evaluate the anterior segments. Standard panoramic or bite-wing views cannot provide the detail necessary to assess this specific defect. These periapicals allow for accurate measurement of crustal bone levels and crown-to-root ratios. We also use them to check crown margin integrity and look for periapical radiolucencies. These data points are essential to differentiate between periodontal disease, combined endoperio lesions, or secondary occlusal trauma. The diagnosis is pathological tooth migration resulting from advanced localized periodontitis. This is likely exacerbated by secondary occlusal trauma on teeth with significantly reduced periodontal support. We must now address the patient's desire to close the diastema. Simply replacing the crowns is clinically inappropriate. With reduced bone levels, normal biting forces cause an exaggerated pivot, which would quickly destabilize the margins of new restorations. For immediate replacement in the upper arch, options include a partial denture or an adhesive bridge. In the lower arch, the patient wants to preserve the lower right canine despite severe attachment loss. This requires a balance between the clinical prognosis and patient autonomy. While preservation can be attempted, it requires documented informed consent, stating that success is not guaranteed. Definitively, periodontal and endodontic stabilization must occur before any permanent restorative work is initiated. An aesthetic gap in an adult patient can be the clinical sign of significant underlying periodontal pathology. Candidates must evaluate the entire periodontium systemically when presented with such changes. Biological stability is the mandatory prerequisite for functional restorative outcomes. Subscribe and share this episode for more clinical deep dives and dental examination prep.